Hello and welcome to episode 25. This is, we are dealing with the version 2 of 4D. Basically, this is a talk show which we are hosting, and we have very eminent guests who will be discussing various topics. We're having a detailed discussion and dialogue in Indian diabetes, and today's topic will be covering diabetes and CKD. Today's topic is going to be covered by Dr. Emmy Grewal. She's done her DM from prestigious AIMS University, and she is currently now a principal consultant in endocrinology from in Max Hospital, Mohali. Madam has received multiple awards in her work in endocrinology, and as a student as well, she has won many posters and paper publications. She has published also in multiple international journals. She's written many chapters in textbooks, so she's the right person to cover this topic. Before I start something more, I want to tell you the kind of unique research Madam has been doing in the field of gestational diabetes, pregnancy, and taking aspects of Buddhist philosophy in diabetes management. So these are some of her unique interests, and Madam will be talking to us about diabetes and CKD. Over to you, Madam.
Thank you, Dr. Abhiraj. So I'll be just presenting my slides. So today we'll be talking about one of the very common complication of diabetes, that is the diabetes with the chronic kidney disease. We know almost 30% of type 2 diabetes have CKD. So we know that in India, the prevalence of diabetes is almost now at present is around 14%. And in our area, and in certain areas like Goa, it is almost 25%. So it is the second highest in the world, and so many percent of patients are living with diabetes. And the problem is that almost 50% of them are not diagnosed. So they are diagnosed late and they end up having complication. Actually, 10% of patients come to us with already with diabetic complications. So we know that CKD, if we look at the CKD patient, the diabetic group form the largest group with almost 40% of them being diabetic. And we know that the main pathophysiology is hyperglycemia, insulin resistance, and all these leads to that. We know that hyperglycemia as such causes glomerular hypertrophy. Then there are other factors, and there is increase in the inflammation, albuminuria, which further leads to increase in the damage to the tubules. We know that initial manifestation is hyperfiltration, and this hyperfiltration, there is increase in the afferent arteriolar vasodilatation that leads to increased GFR, which further is a marker of chronic progressive CKD. So we have diabetes leading to the CKD in almost 30 to 40% of the patients. And if there is a family history, that goes on to 60%. And the important aspect is that with early diagnosis and management, it is to at some sort of stage, it is preventable, and at least we can decrease the progression of CKD in patients with diabetes. So what is the CKD? It is a progressive reversible loss of kidney function. So either it can be kidney damage, pathological abnormalities. What we see clinically is the eGFR, that is the glomerular filtration rate, decreases. So less than 60 ml per minute for 3 months or longer, or the presence of albuminuria. We know that now we classify CKD depending upon the GFR staging and also albuminuria. So either it can be G stage and A stage depending upon the level of GFR and albuminuria. So this is what exactly I was talking about. So that it depends upon the CKD is dependent on the cause, then GFR and albuminuria. We know that normal GFR is more than 90. If it keeps on decreasing, this is how we label it, GFR G2, G3. And along with that, how much is the degree of albuminuria? If it is normal, then it is A1. For example, a patient who has a GFR of 46 and no albuminuria, he will be in G3A and A1 stage. Why this is important? This is where we have to take a decision that we have to continue with the screening or we start the treatment and when we refer it to the nephrologist, because as the patient goes on to these lower from green to yellow to red, then there is a risk of CKD progression keeps on increasing, and also the cardiovascular diseases increase. So we have to be very carefully classify these patients and treat accordingly. So when do we screen? As we know, the type 1 diabetes usually 5 years after the diagnosis, and the type 2 yearly starting at the diagnosis. And how do we screen? These are very simple tests. That is the spot urine albumin creatinine ratio, which is usually in the morning sample, and eGFR, that is the calculated GFR using the creatinine value. So, but for a urinary albumin creatinine ACR ratio, because we know there are many causes like elevated hyperglycemia, elevated BP may lead to increase in the ACR. So we have to have at least 2 values which are elevated. So we should do multiple values, and then 3 values actually has been said. At least 2 values should be positive to say that whether the patient has albuminuria. And we know that if it is less than 30 milligram per gram of creatinine, this is normal. 30 to 299 milligram per gram of creatinine, that is 30 to 299 is A2, and more than 300 is macroalbuminuria or A3 phase, A3, which can be actually identified on the urine routine. So if it is a positive test, repeat and confirm. And sometimes we can use cystatin C, which is usually not done in most of the scenarios. And also we have to look that in certain subgroup of population, it may not be diabetes related CKD. So if patient has rapid progression, significant nephrotic range albuminuria, or an active urinary segment, in those cases, we might need to do a renal biopsies. So for the diagnosis of CKD, it has to be persistent ACR more than 30 milligram per gram, and persistent eGFR less than 60. This in 30 to 70% of the patient, urinary albumin excretion may be normal, but these patients may be again the rapid progressors, or there is evidence of kidney damage, for example, in an ultrasound showing the small shrunken kidneys with loss of differentiation. So what are the strategies for diabetes management? So if we look for CKD, what is more important is that these patients, as in all diabetes, if we act early, at the earliest degree, good glycemic control at the onset will help in decreasing the incidence of microalbuminuria. This was shown in UKPDS that almost 30% decrease in the incidence of microalbuminuria. But there are medication over and above which help in decreasing the albuminuria. The most prominent and promising is SGLT2 inhibitors, and along with that also the GLP-1 receptor agonist. So the SGLT2 inhibitors are the only drug which have shown improvement in the hard clinical endpoints. That is not just improving macroalbuminuria, but also decreasing the progression of decline in creatinine, or improving the renal outcomes, and also decreasing the renal associated death. The DPP-4 inhibitors have shown some decrease in the albuminuria, but the significant effect is seen with the GLP-1 analogs. So these drugs can be used as a fixed dose combination, which is quite commonly used. So where do we use in patients with SGLT2 inhibitors and DPP-4 inhibitors? We know that SGLT2 inhibitors are now the treatment of choice in case the patient has diabetes-related kidney disease, or if patient has a congestive cardiac failure. And the DPP-4 inhibitors can be added accordance with if we want to decrease the HbA1c. We know that these drugs act together and they decrease the HbA1c by around 1.5. And other benefits are that they are weight neutral also, and also have other effects also. So if we see that these are the synergistic combination, we already know that SGLT2 inhibitors, they cause increased urinary glucose excretion, thus improving the glycemic parameter with decrease in HbA1c by 1 to 1.2, and also decrease the insulin resistance. And they have They have been shown to decrease the cardiovascular risk, decrease body weight by 2 to 3 kg, decrease in the diastolic as well as systolic BP. And also, how do these drugs act synergistically? SGLT2 inhibitors, they somehow increase the hepatic glucose production by increasing the glucagon level, which is actually suppressed by DPP4 inhibitors. So here, these drugs have an additive effect. And also, it has been seen that if we combine these drugs, the incidence of genitourinary infection is actually decreased. So these both drugs, when combined together, since they are weight neutral and SGLT2 cause some weight reduction and they do not cause hypoglycemia, they are very useful in patients with underlying diabetes with complications like CKD, cardiovascular diseases, or severe autonomic neuropathy. So what are the benefits of SGLT2 inhibitors? We have talked so much about the benefits, that is the cardiovascular benefit, where they have been shown to decrease the incidence of congestive cardiac failure, which is seen across the spectrum of patients who even don't have any underlying cardiac disease, also decrease the systolic BP. The second important is also in the hepatic also. They have been shown to decrease the incidence of fatty livers. And also in the kidney, as we have been talking, that there are various trials starting from EMPA-REG trial to Credence kidney trial, then DAPA-CKD, and in which it has been shown that these are the only drugs which improve the clinical hard endpoints. For example, there is almost 30 to 40%. In DAPA-CKD, there was 39% decrease in the composite decline in eGFR of 50%, end-stage kidney disease, or death from renal or cardiovascular cause. And also, so other effects we already know. So these drugs have been shown to be one of the best drugs which have shown in patients with CKD. In diabetic as well as non-diabetic patient, they decrease the progression of CKD, decrease the need for renal dialysis as well as transplant, and also they decrease the diabetes-related renal deaths. So where do we use these patients based on the chronic kidney disease? So SGLT2 inhibitors, they can till what eGFR? So the biggest point is that till what eGFR we can use these drugs. The DAPA-CKD, they had taken the patients with eGFR up to 25. So what is recommended by the KDIGO guidelines is that once the patient has eGFR above 25, start these drugs, and they may be continued till the patient undergoes dialysis. But do not initiate if the eGFR is less than 25. And very important point is that at this eGFR of around 20 to 30, there is hardly any effect on the glycemic control, but it is through the other mechanism that it improves the CKD outcomes. So as the eGFR decreases, because the glucose excretion decreases, there is not much efficacy related to the glucose, but the kidney and cardiovascular benefits are preserved. So the DAPA can be used till that, and the DPP4 inhibitors, we know that they can be used up to the very low eGFR. Linagliptin can be used in all eGFR. Sitagliptin and vildagliptin dose has to be decreased. So for all the patients with diabetes and CKD, all patients with diabetic or cardiovascular, we know that we need to have an holistic approach. The Steno study had shown that the maximum benefit is achieved not just by the glucocentric approach, but we need to have a complication-centric approach. So that includes a healthy dietary, lifestyle, and physical activity. Weight reduction also has been shown to improve the renal outcomes in patients. It has shown to decrease the microalbuminuria as well as macroalbuminurias. That's why many times the GLP-1 analogs are also very helpful in patients with diabetic kidney disease. Then smoking cessation, weight management. And the first line therapy, if the patient has albuminuria, SGLT2 inhibitors are first line of management, and they have shown benefit across all the spectrum of eGFR. Normal, to low, patient with albuminuria, without albuminuria, and they have shown decrease in the progression from normoalbuminuria to micro to macro. So at all spectrum of CKD, they have shown improvement. So if the patient has EGFR more than 20, start these drugs and continue till the dialysis. But if the EGFR is less than 20, so these should not be started. And what are the other drugs? Metformin, but in the lower dose if the EGFR is more than equal to 30. And for also, we know that other drugs which help are RAS inhibitors, which help in decreasing the proteinuria and also the progression of disease, and also the statin, because the biggest cause of mortality in patients with kidney disease is cardiovascular disease. So all these patients, we need to manage their weight, hypertension, dyslipidemia. And if the patient is not controlled, we can add DPP-4 inhibitors or GLP-1 analogs. As I already said, that GLP-1 analogs have shown significant reduction in the macro and microalbuminuria, and also by achieving the weight, there is improvement in the CKD parameters. And also if the patient has significant proteinuria, non-steroidal MRA, like finerenone can be used. And also we need to control the BP, and depending upon the cardiovascular complications, the patient needs to be started on statin along with the antiplatelet drugs. So in all diabetic patients with CKD, we need to have an holistic approach. So we can start with the discussion.
So thank you for walking us through this important topic. And today I'll be just mixing it up a little bit, trying to understand because I was very fascinated to see the work that you have done. So I want to bring in your research as well to answer a few of these questions. I hope you don't mind. Let's start off with one of your papers where we were looking at counseling the type 1 diabetes before marriage. I think that was it's a very difficult step, because quite often people don't reveal their condition before marriage, and they feel that again. So what were the one aspect of the question is, what were the challenges that you saw that these women were facing, and how many of them already had early stage of kidney disease when you were evaluating these individuals for that study method?
So we know that type 1 diabetic, these issues are usually not discussed a lot. But over the few years, we have seen the patients do come up that a girl has to be married and what all has to be done. But many times that patient will get married and will come with a pregnancy itself. And once you evaluate, they have a retinopathy and there is albuminuria in significant number of patients who are very long-standing diabetic. And once they conceive, that albuminuria starts increasing and they develop hypertension and there are other adverse outcomes. And in many times, the nephrologist even advise that this pregnancy is going to lead to the significant albuminuria and worsening of creatinine. So what is the thought process is that all these type 1 diabetic, even if they are not married, we have to keep telling the parents that all these things have to be actually thought in, because many times they might not be, because as you know, sir, the follow-up with type 1 diabetics is very erratic. They usually come after an year or so for management. So every time maybe we have to bring in this aspect that once they get married, what all the things they have to done. For example, retina examination is very important because there is progression of retinopathy. Then management of nephropathy. Actually, I have few patients who already have nephropathy, and in spite of telling so many, explaining that this, for example, 3 to 4 plus albuminuria with creatinine in range of 1.6 and 1.7, the patient's parents will, is there any problem in conceiving? Which exactly there is a problem. So those aspects in those patients actually, sorry, your mic is off.
So they will be like, is my kidney fine? Are both my kidneys working? So I think that sometimes that unawareness is quite rampant when it comes to a good group of our patients, I think, and it is very challenging And as you said, but when you were seeing in an institute like AIMS, I think your OPDs would have been almost 400, 500 patients would have been coming every during your, or even more, up to 1,000. I think would be your OPD numbers. So when we're dealing with such a complicated challenge, the reason I'm asking this is because whenever I have worked in rural areas, the patient numbers are huge, follow-up becomes difficult, and we're dealing with CKD. I think we have to be extremely proactive to
Yeah.
screen right from the start. Make sure that we tell them that you cannot, you have to have optimum glycemic control, optimum BP control, all of these things, along with you know the overall management becomes a important step, and it is a challenge. But what tips do you have for the doctors who are dealing with large OPD practices and dealing with large volume of patients having such complications?
Yeah, thankfully in AIMS there was a special diabetes clinic for the type 1. So the things were very much sorted out over there. And the biggest problem in type 1 diabetes management is, one is poverty and ignorance. If they are combined together, then it actually becomes very difficult. So in such cases, actually, because most of the times your time will be spent on arranging insulin for them and getting the things done. So only thing is that every visit we have to educate the patient regarding what are the outcomes they can have problems and how to manage their glycemia. And then they have to have, because even the complication screening till the patients have complication becomes a difficult issue in rural, as you said. I work in actually a corporate setup where the it's quite easy, but once we go to the rural areas, then it is actually very difficult to convince them, because many times what I remember is few girls who have been so badly managed diabetics. Once you start on treatment, they are okay. Their periods became normal, and they felt that this is wow, this is now done. Everything is good. They will not come till they have a next complication. So it's actually, in spite of whatever you do, it becomes really difficult.
So what we adopted in the rural setup where I work, I work partly in Bangalore, partly in rural areas. So what we have adopted is kind of like a every 2 month follow up. So we give them only medication for a certain amount, so
Yeah.
a certain duration of time. So they are bound to come back and get their supply of medicines once we give them free. So that is how we have kind of reduced that aspect of them not coming back for follow-up for years together. So now let's move on, madam, to the next question. Again,
Right.
let's look at lifestyle aspect and the Buddhist philosophy. So what have you
Okay.
learned when it comes to Buddhist philosophy and managing lifestyle, whether it is type 2 diabetes or whether it is kidney disease? What do you feel? What are your takes we can pull from that research paper that you did?
Okay, yeah. If we see, this was a discussion, like we talk of so much problems being faced by even the type 1 patients and type 2. They have so many social issues. In the rural background, the issues are totally different. There, you don't need to adopt much of Buddhist philosophy except telling that whatever you do is like your karma. What type of glycemic control is karma, which will show later on. And you need to have more. These discussions in the patients who are well educated, who have more psychological issues. So here we have to just teach them that you have to like be a very disciplined person. The first thing that is very important in diabetes is discipline, and second is patience. So these are the two things they have to be really careful. And something about mindfulness, that they have to be in the present rather than keep thinking of what will happen next, and they have to manage the things at that point and be mindful of what they are eating, especially, like we talk about mindful meditation and all. They have to be mindful of their eating, and it has to be, they have to enjoy the meal. And yeah, because in poor patient, it's mainly you, it will be some example, you will be telling that this is your karma you are trying, and this will what later on you will show. And
They'll
they
not
don't
accept
have much
it. I think,
they don't
yeah,
have
yeah.
much psychological issues there. It is more in the educated people who are always frustrated with life. There you have to bring on all these Buddhist issues. Yeah.
So I'll tell you one practical aspect. So we were looking into the same aspect of mindfulness as you mentioned, and I did a this is a small work. Again, I need a bigger, larger sample size. So we did first week we put CGM for the individuals who were doing regular meditation, and so we told them 1 week you're not going to be doing any of your mindful exercises, breathing exercises, meditation. You just do your daily walking. So first week was without, second week was with all
With
their daily practice of around 30 to 45 minutes is what the recommendation was.
okay.
And the overall variability, what we saw in the CGM profile, came down considerably and was definitely something that requires now further research. So once we get more numbers, then probably I'll get that out into publication as well.
Yeah.
And it did make a large difference with regard to the intraday variability came down to a large extent. And I think we need to explore more and more of these forms of management. It can't be just like, some basic generic kind of advice we cannot give. And especially when you're talking
Yeah.
about CPT, we need to put in that effort with them to prevent the progression. And thankfully, now we do have the medication to help us. So, tell us your experience with use of GLP-1, SGLT2. How do you feel it has made a impact with the management of CKD? Do you think it is becoming a game changer, or I mean, are we do we need to see more with the current medications that we have?
Yeah, so if we see for in last so many years, these are the SGLT2 inhibitors have actually become a game changer. If you see the amount of data, it slowly started coming with EMPA-REG that it improves the cardiovascular outcomes, and then start coming with the renal outcomes. And as we have seen that over the period of time, it has shown very good results in be in the CKD or in the cardiovascular and initially it was like maybe it is a weight loss which is causing, but we all know that not there is not much significant weight loss. It's mainly 2 to 3 kgs, and which is actually not much. But if we go with the hemodynamics, how it changes the hemodynamics in the kidney by decreasing the EGFR. So the first thing that happens is hyperfiltration, which causes further damage to the kidney, and it by regulating that hyperfiltration, it works. So if I see in the clinical practice, so one, it is help in achieving a good glycemic control without causing weight gain going on fast to the insulin, and secondly, it has helped in decreasing microalbumin urea and all that. We have lots of clinical data, so there is no point which is that it is the only drug which has shown improvement in the clinical endpoints by decreasing doubling of creatinine clearance and all. And if even if with the GLP-1 analogs, especially if the dulaglutide, which is quite patient finds it quite easy to take once a week injection. So lots of patients I have seen significant reduction in the protein urea, because one maybe with the weight reduction and also because a part of the drug effect also. So many of the patients have actually stabilized on the albumin urea has decreased. So even there is data for GLP-1 analogs also. And especially if in a patient with a CKD, we see where so many drugs are actually contraindicated. You can't give sulfonyl urea. There is high chances of hypoglycemia. So the drugs which you are left is SGLT2 inhibitors if the patient doesn't have any genitourinary infections, which is also very common in our scenario. I think it is almost 30 to 40%. And as patients' age increases, that is even more. So adding the GLP-1 analogs in those patients, actually it had improved glycemia, weight maintenance, and also even if we add with the insulin, so that weight does not keep progressively increasing and the GFR somehow stabilizes. So these drugs have been game changer.
Definitely. And I think the main highlighting point is we need to start to use these molecules in the
More
early,
often. Yeah.
more often and early stage of before we allow them to get into the next stage of
Next
CKD.
stage. Yeah.
So this is been a wonderful whole explanation, madam. Thank you for spending time with us today.
Thank you.
And I'm sure a lot of the doctors listening today will take back very important points. So thank you once again.
Thank you for a very interactive session. Thank you.